Welcome everyone to today's webinar, Optimizing the Timing and Site of Care During COVID and Beyond, using machine intelligence to schedule non-emergent deferrals and manage the phasing out of the Medicare inpatient-only list. I'm Anuja Vaidya with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is my pleasure to start today's webinar by introducing our presenters. Dr. Mohammed Saeed is the CMO of Health at Scale and serves on the faculty in the Division of Cardiovascular Medicine at the University of Michigan. Mohammed is board certified in internal medicine and cardiology and has several years of experience as a clinician. Mohammed was an engineering scientist for Philips Healthcare before joining Health at Scale. Mohammed was awarded an MD from Harvard Medical School, an MEng and degrees in EECS from MIT, and a BS in EECS from Purdue. Professor John Guttag is the CTO of Health at Scale, the Dougald C. Jackson Professor of EECS at MIT, and the former chair of the EECS department at MIT. John is a fellow of the AAAS and ACM. John leads the Data-Driven Medicine Group at MIT and is a principal investigator for the Big Data in SAIL. Before joining Health at Scale, John was on the board of Revco Pharmacies, Avid Technologies, and Empirix. John is an alumnus of Brown University and was awarded a PhD from the University of Toronto. At this time, I'm pleased to turn the floor over to Elizabeth from Health at Scale discussion.
Thank you so much, Anuja. I'm Elizabeth Berger. I'm the Director of Growth for Health at Scale, and I'm excited to be here with Dr. Saeed and Professor Guttag to talk through some questions around machine learning, machine intelligence, and how we might think about prioritizing patients within COVID and beyond, and how to optimize for outcomes using decision-making tools to determine things like site of service. Thank you for joining us today. Those were great bios, so I think we'll skip the intros and go right into the questions. So the first question that I have is for Mohammed. So we know that many patients have delayed elective care due to COVID, and this made sense for some time, but what does that mean for patients, health systems, and payers now? And how can we think about how this delayed care may impact outcomes?
Thank you, Elizabeth, and it's a pleasure to be with you folks here today. I think that's a great question. In terms of, the question of, how we define elective care, there's a very large spectrum from things that truly are elective, something at the level of, like, for example, cosmetic surgery, to other procedures that can have a very significant impact on quality of life. For example, there might be patients who have really, really horrific hip pain or knee pain that essentially prevents them from being able to ambulate and move around, and they just become bedbound. And that kind of pain that cannot be treated with just medicines alone is going to have a huge impact on their quality of life. And that can also exacerbate other problems they have, such as congestive heart failure or COPD or diabetes, when you're so immobile and cannot move, obesity. So those types of treatments, for example, doing a elective hip replacement or knee replacement in certain patients can have a tremendous impact on not only the quality of their life, but on other aspects of their healthcare, including things that affect their cardiovascular system and how well they breathe and move. So in terms of COVID, we saw lots of patients who didn't have these kinds of treatments available to them during the peak of the pandemic, and that really impacted the quality of their life. In terms of the health system, we saw a big drop in revenue because a lot of these elective procedures are a very significant source of their revenue. And also a lot of frustration because as physicians, we know we have patients that we really need to reach. As a cardiologist, we were seeing patients who were staying home with chest pain because of their fear of COVID and literally having MIs at home or having horrific congestive heart failure exacerbations at home untreated, and they had disastrous outcomes from those. So as a physician, not only just from a revenue perspective, but it's also very frustrating to see that you can't get your patients to the hospital when they need your care the most. And then from a payer perspective, they've certainly payers did see a decrease in their elective procedure volume that they would be, financially responsible for. But eventually you're going to have a huge backlog of these types of patients. And then the problem becomes in how you prioritize these patients given the, basically constrained resources of the health system. On top of that, we're still not out of the woods yet with COVID. And so how you deal with all these different variables in this complex environment, I think, is still an ongoing challenge.
Yeah, that's a really great answer. And what you said about patients having MIs at home, I mean, that's so scary to think about. A question for both of you, maybe first to Mohammed, is since this is such a problem, how do you think about prioritizing which patients should come in to have care? And, are there ways to use technology to support that process, John?
Yeah, so I have to, first of all, thank you for having me for the webinar. And as Mohammed says, COVID is not over, which you can tell by my COVID haircut or lack thereof, which I'll also apologize for. So I'm not a physician, I'm a computer scientist. And so I asked the question, can we use technical tools? And I don't want to say to prioritize care in the sense that that's often a human decision, but can we at least use technical tools to predict care, providing or not providing care, which I want to emphasize is not quite the same as prioritizing things. And the answer, I believe, is yes, we can. We can predict who is at, say, highest risk of an MI, and certainly suggest that those people see a physician as soon as possible. It's something that, fortunately, we've been working on for quite a long time, we as in the field. We've been using various artificial intelligence methods, mostly machine learning, to build predictive models about which individuals are more or less likely to have an adverse event within various timeframes. And so my answer to your question would be we should use such models to understand the probability of various individuals having adverse events. And then society needs to make decisions about how to use that information to prioritize care.
Mohammed, anything that you would add to that?
I think John is spot on. And, I think one of the things that I'd like to say, both as somebody who's, has a boot in the physician camp as well as in the, the quantitative and analytics camp, is that these variables sometimes can get very high dimensional. So when you are saying, well, is this a complex patient or not? The simple rules that we try to develop for trying to address these types of things about who should be prioritized, sometimes rules just don't encompass all the possible combinations and permutations of problems, lead to patient complexity. So for example, if it's not just the patient, going back to the hip replacement or knee replacement patient, these patients can have on top of that untreated heart failure or COPD. They could have had, poorly controlled diabetes, and they could have had prior hospitalizations. They could be on very complex medicine regimens, and making sure that those types of patients are tapped into the healthcare system when healthcare is needed most for them is a very daunting challenge. And just simply coming up with a, one or two variable rule to address that, I think in my view is very insufficient. And I think that's where, I think the points John's bringing up about using machine learning to try to identify these types of high dimensional patterns that can be then used to identify who the patients are that need the care the most.
Yeah, if I could be technical digression, I've been in the AI field quite a while, and for a long time, we attempted to build medical systems that were rule-based. We would interview doctor after doctor after doctor, try and understand the rules they use to make decisions, and then encapsulate those in these complex rule-based decisions. If this, then that. If that, then something else, et cetera. And they never worked very well because, as Mohammed intimated, the rules are complicated. And a lot of what a physician sees at the bedside, they really can't articulate into a simple set of rules. And so in recent years, as machine learning has become a more viable technology, we've moved pretty much entirely away from the rule-based systems to data-driven systems, where we collect large amounts of data about populations, look at the outcomes, the various outcomes that the individuals have, and from that, try and learn using automated tools how to associate information we have about a patient or a person really prior to the event to the probability of an event. So it's a very different way of thinking about things than rule-based systems. The thing I should say, though, is what we get out of these is a probability. And the question is, if we say the probability of an event is 0.8, it then becomes a human decision what to do with that probability. Because there's a 20% will be just fine if we say it's 0.8. And these probabilities, while they will be true over the population at large, don't actually tell you anything assuredly about any individual. And I think one of the things we have to spend time on is making sure that the people who use these systems come to grips with what probabilities really mean and what they don't mean.
Definitely. And before I get into some other questions on other applications of machine intelligence, to both of you, what do you think is the level of usage of these types of machine learning systems? Because it sounds like it's been quite an evolution from rules-based to true machine learning, and I imagine that different players in the spectrum are using different versions.
Mohammed, you want to go first?
Thank you, Elizabeth. So that with respect to this type of how do we use machine learning in healthcare today, my answer is that it's actually not very well penetrated yet because of many of the challenges that John has talked about and other challenges on top of it. I would say that we are really just at the dawn of using machine learning in healthcare. I think what we're doing with Health at Scale in terms of some of our deployments, I would say are among the largest in the country, where we've actually used machine learning, for example, to match patients to the right specialists. And we have deployments for looking at patients and looking at their complex characteristics and then matching them with physicians who've taken care of similar patients like the patient being considered. That would be an example of a machine learning application that's found its way into healthcare. Back in the days when I was in the patient monitoring world, we were trying to develop arrhythmia algorithms that can identify people that have lethal arrhythmias. But even, at that time, when we were building these algorithms, the big problem were the false positives, that when you had these quote unquote red alarms, 99% of the red alarms that we were ringing in the ICU that were coming from these quote unquote smart monitors were in fact false positives. And it led to this cry wolf syndrome where people started having less faith in the algorithms that are responsible for these types of alarms. So I think one of the big leaps that we've made is that in the last 20 years, there's been a massive volume of data we've collected. And also there have been some tremendous advances in machine learning to find the subtle patterns in these huge volumes of data that really will allow us now to build the types of algorithms that will be very useful and can actually help physicians, nurses, healthcare administrators in making better decisions to improve healthcare delivery.
Well, fittingly, Mohammed answered the question from the perspective of a physician. And at the front lines of clinical care, I agree that the penetration of artificial intelligence has been small. In healthcare writ largely, it's been considerably larger. For example, machine learning is widely used to do coding. Hospitals who go and try and code in order to maximize reimbursement use machine learning. And on the other side, payers use machine learning to do things like look for fraud, waste, and abuse. And so if you move beyond the actual clinical care, there's been substantial penetration. If you go look at the pharmaceutical industry, machine learning is widely used now to help design drugs and make important impact in that. So we've seen a lot of penetration in healthcare broadly, but relatively little at what I would call the clinical front lines. It's used a lot in research studies in healthcare. People use machine learning to do population studies with MRIs and things like that. I agree with Mohammed that that's about to change. I certainly am proud that Health at Scale has got a very substantial impact in using machine learning to actually improve people's medical outcomes. One of the things to think about is, and I keep coming back to this, is human in the loop machine learning, where we produce recommendations, we don't make decisions. And then humans have to see the recommendations and mediate them with human intelligence. Over time, hopefully, that we'll make better and better recommendations and humans will learn to accept them more and more frequently. I think places we're going to see impact very soon in clinical capacities are in things related to imaging. Computer vision is very good. And in areas like pathology and radiology, we're very close to the point where we should be introducing much more artificial intelligence directly into the clinical pipeline than we have now. And again, as Mohammed said, recommendation systems are very useful. People use machine learning to decide what movies they want to watch. People use machine learning to decide who they might want to date. It's about time we use machine learning to choose physicians or help choose physicians and other things of that nature. And certainly the capacity to do that in a constructive way is already here.
Thank you for walking through that. I definitely have a better understanding of all of the opportunities there. And as we've seen technologies advance, especially through COVID, we've also seen the advancement of a lot of trends that have been happening already, such as the adoption of telemedicine. And that presents another opportunity for patients to be seen and potentially seen earlier than if they were to be seen in person. What are some other technologies and innovation opportunities you see in this space to figure out how we might send the patient to the right site of service and make sure that they get care in the right site?
really good question. And one of the nice things we've seen with telemedicine is we can expand the number of possible sites. It doesn't have to be people who are within a short distance of your home. It doesn't. This gets back to what I was just talking about the matching thing. And I think you need to think about it on an individualized basis. If you're trying to decide who a person should date, you don't just generate, say, here are the 50 most attractive people that anybody should date. No, you try and choose people appropriate to the person looking for a date. Most of what we see in medicine doesn't do that. You can look at reports. These are the 20 best cardiologists in your area. And that's just the wrong question to ask. You should say, no, I want that. I want to know who's the best cardiologist for me. By the way, that's always Mohammed, but setting Mohammed aside, you might want to ask that question. Mohammed talked about hip replacement earlier. I had my hip replaced about a year ago. And I actually used artificial intelligence tools, machine learning, to generate a list of hip surgeons in my area were well matched to my age, my athletic condition, things like that, and choose somebody who would be appropriate for me. And that's probably would be appropriate for a professional athlete. It's probably not the same person who would be appropriate for a 14-year-old girl. These things are all different. It may be not the same person who needed their hip replaced because they've been in an automobile accident, as opposed to just getting older. And so I think what we're seeing is an advance of matching individuals to appropriate caregivers. And it can be the institution as well. What's the appropriate institution for me or for a particular person? And I think that's what these machine tools allow us to do, because they can look at everybody in the country and try and figure out who has the best outcomes for certain kinds of patients. My primary care physician, who I think is an amazingly talented physician, just doesn't have the data at his fingertips to answer all of those questions. His experience is based upon who he sees, not everybody. And with telemedicine, we can see people for a lot of, not for surgery, but for consultations, for second opinions. And I think the whole second opinion business could be changed pretty dramatically. Even for something like hip replacement, the truth is, to decide whether my hip needed replaced, they didn't actually need to have me in the doctor's office. Between the images and what I could say in an interview, they would know what they needed. They didn't actually need to lay hands on me. I say that because they didn't lay hands on me. So I think there are a lot of opportunities now. And as people are more comfortable with the idea of telemedicine, it opens up a lot better avenues for connections.
And Mohammed, from your perspective as a clinician, how have you seen patients think about different opportunities to engage with you? And how have you seen some of these technologies pop up in your clinical practice?
That's a great question. So, again, I've seen, a big rise in the amount of, telemedicine consults I do with patients. I would say this time a year ago, I was maybe doing, and I was one of the early adopters of telemedicine in our institution, and I was doing only, a few a month. And now almost half of my patients that I see in my weekly clinic are basically telemedicine patients. So a big jump in that. And, it's telemedicine, for some folks, it's the right thing for them. I live in Michigan, Ann Arbor, and I actually did telemedicine consults with folks in the Upper Peninsula. That would have been a very long drive for them all the way to spend 15 or 20 minutes or 30 minutes with me. So having the ability to do telemedicine for people based on distance, as well as based upon, as John was touching on, the problems that they have that could easily be discussed with them over a video link. I think that works great for some patients. For other patients, they had some frustration with telemedicine, and they couldn't wait to get back into the office and see you face to face. And knowing what patient would benefit telemedicine versus what patient needs face-to-face interactions, I think, again, there's a role for machine learning there to help in basically putting the patients in two different queues to make sure they're in the right place. Other technologies, I think, that are emerging technologies in this COVID and post-COVID world would be remote home monitoring. So, for example, in cardiac electrophysiology, which is a specialty I'm in all our patients who have defibrillators and pacemakers, they have home monitors, so we can keep close contact with them at home, see how they're doing during the COVID crisis. And I think that was a huge advantage for some of our patients. Now, with advances in mobile healthcare, smartwatches, smartphones, and other types of wearables, I think there's going to be a tremendous role for mobile monitoring and how that can be used, for remote healthcare to, again, in situations like COVID, as well as, even without COVID, can we do a great job of taking care of patients while they're at home?
Yeah, and chiming in on that, it isn't necessarily going to be the things that you would traditionally of as clinical. I think of monitoring, for example, of elderly people. You might notice that someone is unusually not moving, that they've been sitting in front of the television for 8 hours, which is atypical. And just finding anomalies where people are behaving differently from the way they usually behave can be an alert that something is going on that maybe needs an attention. And we're getting better and better at things like anomaly detection, where we, again, don't build averages, but we build a model of an individual's normal behavior. And then we can tell when they're deviating from the normal behavior and perhaps intervene. And maybe the intervention is something as simple as a phone call to a loved one saying, gee, dad hasn't been very active today. Give him a call and see what's going on. So I think there are going to be a lot of opportunities going forward once we can do that. And of course, in doing so, we need to be cognizant of issues of privacy and things of that nature. And so we need to make sure that we use technology in a way that's not overly intrusive and invasion of people's privacy.
Mm-hmm. It's very exciting that all of these new technologies and new trends are enabling more data about patients, more personalized recommendations to support each individual's care. One thing I want to bring up, so a lot of our audience, I'm sure, knows that Medicare has proposed to eliminate the inpatient only list to allow more procedures to be done in outpatient settings. That's another shift that the health system and that payers will need to accommodate for. And it seems like for a lot of patients, that shift could make sense, but perhaps not for every individual, that some individuals may be better off in an inpatient setting, or perhaps some may be better off just staying at home and doing a telemedicine visit. Do you think that machine learning will be important to be able to support this transition, and how might it be used?
So it's hard for me to speculate on whether it will be important, because that a lot depends upon whether it's adopted. Easier to speculate on how it could be used productively. And it's not entirely speculation, in that we've actually have built predictive models that will look at an individual's medical history and look at a particular, say, procedure, and make a prediction about whether the patient would be better off having it as an inpatient or an outpatient basis. And these things are surprisingly predictable. again, with the usual caveats about predictions are not perfect, but you can really do that. And in some sense, it's not surprising. If you think about pregnancies or giving birth, medicine has long had the practice of classifying some births as high risk and saying those births should take place in the right institutions, and other births as low risk, and arguing that in fact, mother and child would be better off in, say, a community hospital. And people have been doing that for quite some time, using what Mohammed previously described as rules-based, sets of rules of thumb. But now that we have a lot of data and better technology, we can extend that and do a pretty good idea of projecting where you would get the higher probability of a better outcome. It's not always the case that places that are best equipped to deal with high acuity individuals will yield the best results for everybody. And maybe Mohammed, as a physician, has a somewhat different take on it.
I think your points are spot on, John. I could tell you that I've worked in different types of medical centers and healthcare settings. Out in a community hospital where I was the hospitalist working as the only physician there overnight with 3 or 4 floors of patients. And in such a setting, I remember a case where somebody who had an elective gallbladder removal but had a complication in the middle of the night, and it became septic, had atrial fibrillation, and we had to move that patient to a higher that could manage a patient like that. So, that type of complication could happen to patients. The question was that a predictable type of complication that could happen in somebody who was otherwise high risk? So, right now, as John was saying, a lot of these kind of decisions are made by rule-based human intervention. But we are getting more and more data where we can start actually identify which patient should go to what type of setting. So that, I think, is an area where that's ripe for innovation. One of the things about healthcare is not only just about outcomes, but it's also about costs. You have to think about the costs associated with having manual review of hundreds and thousands of cases and trying to figure out which bin should they go into. Now, imagine having a system where you had a computer that could help and make that a more efficient process. So the amount of administrative overhead that we have today, having systems in place that can make that a more efficient process can not only lead to better decisions, but also greater efficiency and reduce costs and administrative duties.
That's great. And bringing this, great technological discussion back to thinking about COVID and how we might be able to bring in patients who really need to be seen versus make a care plan for patients who can be seen Mohammed, from what you're seeing in your clinical practice, do you think that patients are ready to come back to the health system to be seen inpatient or in general in person, or is there some hesitancy still there?
It's a great question. I think that, where I'm working, I think we're seeing volume to, close to pre-COVID levels for lots of elective procedures and things like that. There is still some hesitancy. When we're going into a hospital now, everybody wears a mask. Everybody has to go through a questionnaire. Things are not back to normal. As I said earlier, we are not out of the woods yet. So questions like, should I come to my clinic visit and get my flu shot? Well, I would say absolutely yes, you should get your flu shot, because that can also be a tremendous source of morbidity and mortality in a large healthcare settings in the U.S. But you do see hesitancy in getting flu vaccines and things like that. So getting the word out and making sure that people do the right type of care they need for things like vaccines, make sure that they get the types of interventions they need for, the chronic diseases like diabetes, congestive heart failure. patients really those are not luxuries that patients can afford to let go, because if that can lead to disastrous consequences in their overall healthcare. There is that fear, but we also need to come up with education, and we need outreach to find out who those patients are that need the care the most. And again, that's, I think, where, basically trying to intercept those patients early on with, again, using machine learning technologies and other ways of identifying the high-risk patients can help them overcome their fears of, going back to healthcare settings and getting the care that they actually do really need.
That's great. I personally just got my flu shot a few weeks ago, so feeling good about that decision. And to wrap up this discussion, you both have talked about so many different applications of machine intelligence, both within the COVID world and as we think about transitioning out of the COVID world. I'm optimistic that we will get there. What are some other applications of machine intelligence that you both have been working on specifically at Health at Scale?
Well, I just want to bring up one other thing related to COVID. And what we have seen is, for the first time, the US public getting genuinely interested in analytical models, right? We've all seen these models of various things about, flattening the curve and predicting deaths and all of these things. And I'm very optimistic that the public awareness of the role of science and mathematics in particular, and predictive models that we can build, actually has an important role to play in healthcare. And so I'm sort of hoping that will be one silver lining to this very dark cloud, will be a wider appreciation of the role that analytic models can play in real issues. All right, I know that wasn't the question you asked, but I wanted to get it off my chest anyway. So you asked what we're doing at Health at Scale. And we're doing a lot of things. We've already talked about matching, and we've talked about matching people to physicians. We've also done a lot of work on matching people to institutions, in particular looking at post-acute care. As the medical system wants shorter and shorter hospital stays, many people end up going to a skilled nursing facility as kind of a halfway house between the hospital and home. And unfortunately, results in those places are very uneven. Particularly amongst the, say, Medicare population, there's a very high rate of people who, rather than going home from the nursing facility, go back to the hospital. We spent a lot of effort at Health at Scale trying to figure out how to reduce the readmissions, reduce length of stay, healthier, faster from these nursing facilities. And what we found there is choosing the right nursing facility for people is very important. And a lot has to do with comorbidities. So an elderly person who is in the hospital or facility recovering from a stroke might need to go to a different place if they have a history of respiratory than if they have a history of cardiovascular problems. Different places do differentially well in different classes of patients. So that's one whole line of again, matching. We've done work on intervention, trying to discover people, not to close the barn door after the horse is out, not to say, oh yeah, this person has been a heavy user of the medical system, they'll probably be a heavy user next year too, but who is on their way to becoming a heavy user, because that's an indication that their health is deteriorating. And identifying those people early, but not just that they're at risk, but why are they at risk, so that you can imagine what a suitable action would be to intervene. And the final set of things we've done, I've alluded to earlier, is we've gotten very interested in reducing the amount of waste in the US medical system. A vast amount of money is spent on things that do not contribute to better outcomes. And we're hoping that we think we can identify a lot of such wasteful use of the medical system using artificial intelligence, and by identifying it, learn to it. So that's a very quick summary. And Mohammed, you want to add anything?
John, I don't think you left me much. So, but maybe just a point I'd add about fraud, waste, and abuse is that it's interesting that with the pandemic, there was some levels of things that were wasteful before that actually have gone down in volume. But as we get out of the pandemic, there's going to be this. There could be this resumption of again, wasteful procedures and things like that. And being able to identify those, again, instead of using rule-based systems, using real data-driven machine learning, I think is one of the big value adds that we have at Health at Scale. So, there's going to be, a flood of procedures, a flood of testing happening as more and more hospitals get back online and start getting the patient volumes they had before and dealing with that backlog. And that overwhelming avalanche of patients and procedures, that's where I think having a system that can readily identify those patterns in there that could be fraudulent, could be wasteful, could be abusive, would have a great impact in reducing healthcare costs.
Perfect answer. Well, thank you both, Mohammed and John, for answering my questions. I'll now hand it back to Anuja to take some questions from the audience.
Thank you, John, for that fantastic discussion. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. Okay, great. We have a couple of great questions coming in already. Let's start with this one. We hear machine learning and artificial intelligence thrown around in healthcare a lot these days, but how can you determine what is truly machine learning?
That's an interesting question. We see it's not just in healthcare, by the way. I was talking to a colleague at MIT who was writing a research proposal. And he came to my office and saying, I need to sprinkle the machine learning fairy dust in my proposal before I submit it. Everyone sort of wants to somehow be connected to this train right now. From a technical perspective, I like to separate machine learning from statistics. Right, statistics is set of mathematical tools for really checking hypotheses. Do we think this is true? Is it really? Why we use them in randomized clinical trials. Machine learning is more about taking the data and, in a sense, almost generating hypotheses. It can be used to find out things we don't know. So, for example, we can take extensive data about people and build a model that from that data predicts outcomes. That's very different from saying the rule-based or statistical-based notion of if this, then we think this will be the outcome. Here, we're actually learning it. Now, in some sense, once we're done, we could claim now we're back to statistics. But we didn't know what we were looking for, and machine learning can find it for us. Ideal question, of course, that people should be asking is not, are you using machine learning, but are you getting better results than other people have gotten? And we use machine learning not because it's cool, but because it actually gives us better predictions than we can get any other way. And so to me, the more relevant question is not, are you using machine learning, but are you getting good answers?
Great, thank you so much for providing those details. So our next question here is, a lot of care has been delayed by COVID, but also COVID has helped to reduce the amount of low value care delivered. How can we ensure that a return to normal doesn't come with a rise in low value care?
That's your question, Mohammed.
Well, thank you, Anuja. You know, as I was alluding to earlier, yes, we did see a drop in certain types of wasteful or low value care during the peak of the pandemic. But again, there's a backlog of patients. And as we start having patients come back to the hospitals, come back to clinics in big volumes, and on top of it, there's actually been cut back healthcare staffing because of the big budget cuts that healthcare institutions have had. You know, that's going to be a big challenge. And again, this is where the data challenge comes in, is how do you identify what is truly wasteful, what is truly low value care? There can be rule-based approaches to that, but then there's this other area where we would call more of basically looking at the patient characteristics and using the unique individual characteristics of a patient and identifying, would they benefit from this procedure? Would they benefit from this diagnostic test? And using that, you know, in the value-based care world, they call this clinical nuance. Physicians can do that, or caregivers can do that on a person-by-person basis. But now that we have these big data sets, we can also train algorithms to identify the subtleties in the data that would match this concept of clinical nuance and identifying what truly is low value versus high value care, and making sure that we prioritize the high value care and catch things that are low value or wasteful, and worse yet, fraudulent. And so I think there's a great role for machine learning there in identifying these types of patterns.
Yeah, I completely agree with Mohammed. One thing to think about when you say is what's low value and what's high value is, in some sense, it's of value if it improves the outcome of the patient by some reasonable amount. In order to answer that question, you need to know what would have been the outcome absent the treatment, absent the test. And so one of the things we do with predictive models is we can project what the outcomes for individuals across, say, a large population would be. And then we can ask the question, did the people adjusting for acuity, did the people who had this test or this procedure get better outcomes than those who didn't? And that will give us at least a more objective way to think about the question. But it's not easy. It's a complicated thing.
Absolutely. Thank you both for providing those insights. We have time for one last question here. What are some strategies that you use to convince patients that they need to be seen in person for care?
So, you know, that's always a challenge in terms of how to get the patient who may be a little skeptical or fearful to come in to get the care they need. And, you know, again, as somebody who is both a physician as well as a data-driven scientist, I actually try to resort to the data and tell them that, you know, based upon what we know about people like you, that if you were to get this treated, you are likely, for example, to live longer. You're likely to have a better quality of life. And I talk to them in great detail about the risks and benefits, and we try to make a decision together. I try to make sure that they understand. So first of all, I think as a physician, my job is not to just to dictate to them what to do, but to help them understand their disease, understand the treatments, and understand what the risks and benefits of treatments versus simply just doing nothing are. And I try to use data as much as possible. And I readily admit my ignorance to patients and say, you know, as cardiologists, that's one of the specialties where we use data a lot. And when I have the ability to talk to them about a large randomized clinical trial that had people like them in the trial, I use that. But, you know, also there's times where I have to just basically go on my clinical skills and reasoning and say, you know, we don't have people exactly like you in a clinical trial, but from my experience, these are the risks and benefits. And, you know, I say, you know, in somebody like you, you should probably get this done sooner rather than later. And in other folks, I might tell them, and let's readdress things in a few weeks and, you know, take it step by step. But again, in these cases, it would be great to have tools available where there is no exact randomized clinical trial on exactly the patient I'm talking to, where I can actually use clinical decision support tools to give me more quantitative-based analysis I can use in my clinical decision making. So what we call this almost like in silico clinical trials, where we can look at massive volumes of millions of patients and say, within these millions of patients, are there patients exactly like my patients or similar to my patient that I can use for helping to make a decision about my patient? And that's where I could not do that on the fly. And I don't have access to these data sets as a physician. But where if we had very robust machine learning algorithms that could tease those patterns out, those subtle patterns out, they could be of great use in helping, you know, make better decisions for patients.
Absolutely. Thank you so much for providing those strategies, Mohammed. We're coming up against the end of our time here, but before we close out, I do want to ask Mohammed and John, do you have any final thoughts you'd like to share with us?
Be optimistic. I've been in this field a while, and every time we've tried to inject algorithmic thinking, machine learning, AI into a field, there's initial skepticism. Before I got involved in healthcare, I was working in finance, and people were skeptical. Now there isn't anyone in the world of finance who doesn't rely heavily on algorithmic tools. I run into a lot of skepticism from physicians who think that we're out to replace them with artificial intelligence. We're not. Artificial intelligence is not going to replace the physician, but it can make the physician better at their job. And it can, as Mohammed was just saying, help inform the patients about the decisions they need to make, and let the patients and the physicians work together. So it's not, do we want a doctor or do we want an algorithm? We want both.
And I completely agree with John. You know, I think that we are seeing, you know, massive changes in terms of technology trends in society at large. We're seeing folks having access to electronic health records. We're seeing data that is now more increasingly mobile and electronic in nature instead of paper. We're seeing use of smartwatches, smartphones, and the ability of having computers that can analyze these massive at lightning speed. So you put together those types of technology trends with folks who are well, you know, schooled in computer science, machine learning, as well as healthcare delivery and practitioners of healthcare. I think that really allows us to build the types of technologies that can make a great difference in healthcare. And as John was saying, I think that we should be optimistic about this. You know, we're going to go through a growth phase, a learning phase, and how to use and operationalize these systems and get that last mile implemented correctly. But I have no doubt that you know, machine learning and AI will become an important component in healthcare delivery of the future. We really need to adopt you know, that attitude and, you know, learn to use it in the most judicious way possible.
Thank you both for your thoughtful remarks today. And that is all the time that we have for today. I want to thank John and Mohammed again for the excellent discussion, and Health at Scale for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.